Okay, these next set of slides will be on anatomy and physiology and reproduction. Now, I'm going to be honest with you, a lot of these slides are just for your review and is not going to be tested on the first exam. Now, there will be some material from these slides that will be testable, but I will let you know what those are. So I'm not going to go over a lot of these slides word for word. This is just some things for you guys to be aware of when we're talking about labor and delivery and postpartum, and these are just reviews of the different anatomy and physiological properties of what's going on with reproduction and pregnancy and delivery. So this is just an example of going over terms of the different anatomy features that we're going to need to be knowing during this time, and just some things we need to kind of refresh our memories. So for instance, we talk about the labia. So it's important to remember that this is the protective coating the skin over the vaginal opening, but the part that I want you to focus on is that it's highly vascular and it's abundant in nerve supply. So that would be important to remember when we talk about labor and delivery and we talk about cutting an episiotomy or having a tear in the perineum or the labia, and understanding that the vascular component to how the blood loss can happen during this time, or how painful it could be because there's an abundant amount of nerve supply there. So this is where I just kind of want you guys to review a little bit of your anatomy and physiology. The next slide, same thing, just kind of reminding you where everything is and all the names of it, just for your refresher. Understanding that there is a unique sensitivity to the clitoris, that there are more free nerve endings of sensory reception located in this tiny area than any other part of the body. So this is important to understand again in delivery and getting those areas numbed by epidurals, spinals, local anesthetic when we're doing not only having the delivery, but we're repairing tears that happen down in the perineal area, and understanding how painful this can be for moms if they're not properly numbed or medicated. The cervix, this is the lowest part of the uterus, and this is what opens into the vagina. So not only is this where menstruation occurs, but this is also what we're talking about at that end part of the birth canal. So it is the opening measured during childbirth. So we are actually measuring the cervix by doing a vaginal exam with our fingers, and we are measuring it subjectively, obviously. When the cervix is not open, we call that 0 centimeters or closed. And then once it starts to open, we say it opens between 1 and 10 centimeters large. When that opening of the uterus, which is that cervix, is open to 10 centimeters, we call that complete dilatation. So it's completely dilated, as big as it's going to get, which is about 10 centimeters. And this is when a woman is ready to push the baby out from that cervical standpoint. So that's how far the cervix has to dilate, or how open it has to get in order for a baby's head to be able to fit through there. So again, I'm not going to go over some of these slides. This is just going over the pH environment and how fertilization occurs. I'll let you guys kind of review that on your own. These next few slides will not be testable material, but just to kind of let you guys do a review of this. So I'm going to kind of quickly go over that. I will mention that if a woman is trying to get pregnant, her temperature will elevate during the times that she's ovulating. So oftentimes when we have women that are trying to get pregnant, we will encourage them or educate them to take daily temperatures. And when they notice that their temperature is elevated by 0.5 to 1 degree, it's most likely that she's ovulating at that time, and it's the best time to try to get pregnant during that time when ovulation is occurring, fertility is going to be high. So just another thing that you might see in that pregnancy counseling when someone is trying to get pregnant. Again, some more slides that are for your review on the whole endometrial cycle. So I'm going to go ahead and pass through those. I want you guys to take a chance just to review those. And I'll let you know when we get to the point where we need. So this is a slide that you would need to know. So when we're talking about estrogen and progesterone, estrogen is the development and the maturation of the follicle, and the progesterone is what's secreted by the corpus luteum, and progesterone is what reduces uterine contractions, which allow pregnancy to be maintained. So at the beginning of the pregnancy, progesterone is high. It's what keeps the smooth muscle of the uterus from contracting. When women are having difficulty with preterm labor or having frequent miscarriages, oftentimes in the early stages of pregnancy, it has to do with an imbalance of this hormone or maybe not enough progesterone produced by the woman. It's often ordered that they do progesterone suppositories weekly to increase that level of progesterone and to decrease the amount that the uterus contracts so that they can maintain that pregnancy. So it's important, this is another testable slide, where prostaglandins, it's important to understand that these are not hormones, but they are hormone-like. They are produced by all tissues, not special glands, and they mediate the body's inflammatory processes. They are essential for normal reproductive functioning. So you need these prostaglandins to be able to have normal reproductive functioning. And they're present in large amounts in menstrual blood. So that's important to understand about prostaglandins. Genetic counseling is a good part of preventative health process when we can speak with individuals or families that could possibly be at an increased risk for an inherited disorder. And this is compared with preconception counseling. So these are different genetic counseling that we can do when a couple is deciding to have a baby and maybe have some familial inherited traits where they're worried about the possibility or the likelihood of having a baby born with a genetic abnormality. We can include in this genetic counseling risk evaluation, probability of development or transmission of a specific trait or condition, and the options in management or prevention of that, and informed choices that are given to them. So that's the goal in genetic counseling. So types of patients who may benefit from this genetic counseling: anyone who's got a maternal age over the age of 35 years old, we call that advanced maternal age, where you're at an increased risk for some of these genetic abnormalities. A paternal age of over 50. So it's important to understand that sperm ages as well. And when you have a father who's over 50, that increases risks of a baby having some genetic abnormalities. Having a previous child or parent or close relative with an inherited disease, a congenital anomaly, a metabolic disorder, or a chromosomal abnormality may put you at a higher risk of having a child with one as well. So this is a person who might benefit from counseling. If there are any blood relations or incest, so in some cultures, in some areas, it's not unusual to marry a cousin or a second cousin, and in those cases they have an increased risk of genetic abnormalities of their offspring. So that would be someone who would have a vested interest in genetic counseling. Anybody who's had a teratogen exposure, and I'm going to explain that here in a little bit what that means. That's anything that can be harmful or fatal to the fetus if exposed to it during pregnancy. Anyone who's had 2 or more pregnancy losses, and maybe having genetic counseling, you can find out that there's maybe something you're carrying, some sort of inherited disease, or you have some sort of disorder that's causing you to miscarriage. Or anyone who's had the history of a stillbirth, especially a stillbirth with an unknown cause. So preconception counseling is the best way to provide this type of counseling before pregnancy. It's offered to all women. There's serious ethical and moral issues that need to be considered and that need to be raised based on termination or inconclusive yet convincing statistics. So preconception care, the goal is to identify and modify biomedical, behavioral, and social risks to a woman's health of pregnancy outcome through prevention and management interventions. It can occur any time before conception, and we are looking at risk factors for adverse outcomes. So this would be someone who maybe is a smoker or who's using alcohol or drug use. We can counsel them on quitting the smoking, the alcohol, and the drugs based on what we know are the risk factors to both her and the fetus if she continues these behaviors. This is also one of those things where we talk about not taking your folic acid supplements. We're going to talk about that in the antepartum section, that it's important to take folic acid supplements to help prevent neural tube defects. And you need to take that before becoming pregnant. If you have a mom who's obese, preconception care can recommend that she lose some weight before trying to become pregnant, as obesity is a big cause to a lot of difficulties during the pregnancy, as well as conditions that can occur to mom, like gestational diabetes, hypertension, preeclampsia, and can also cause risk factors to the baby as well. And then any kind of prescription medications that she may be on that are teratogens, so those are those things that can be harmful to babies that maybe she doesn't realize can be harmful. So an example would be Accutane. A lot of people use Accutane for acne, but that is a teratogen, meaning that you cannot be on that medication when you're pregnant because it could become fatal to the fetus. So if you didn't know that, preconception counseling could help you kind of know what medications you should be going off of before you get pregnant. And then anybody who has a pre-existing medical condition like diabetes or HIV, counseling is needed before you get pregnant to understand the stress that pregnancy puts on the body and how that can affect both your health during the pregnancy as well as the baby's. So a teratogen is anything that interferes with the normal embryonic or fetal development. So it's any substance, organism, physical agent, or deficiency state that's present during gestation that is capable of inducing abnormal postnatal structure or function by interfering with that embryonic and fetal development. So it's anything that crosses that placental barrier is of concern. So examples would be alcohol, certain drugs, certain medications, certain infections, and those infections would be herpes, rubella, and chickenpox, just to name a few. So if the mom were to contract herpes, rubella, or chickenpox during her pregnancy, that can cause abnormal postnatal functioning of the infant because of the disruption of the normal fetal development. So a common lab or diagnostic test we might do when we're looking for certain genetic disorders, one is called an alpha-fetoprotein, one is an amniocentesis, we have chorionic villi sampling, percutaneous umbilical blood sampling, fetal nuchal translucency, a level 3 ultrasound, a triple and quad screening testing, and pre-implantation genetic diagnosis. So we'll go over a few of these. An amniocentesis can be done as soon as there's enough amniotic fluid to test. That's usually about 15 to 20 weeks in the gestation. Amniotic fluid is then aspirated and evaluated for chromosomes and alpha-fetoprotein, DNA markers, viral studies, karyotyping, cystic fibrosis, and sickle cell traits or disease. The risk can be of an amniocentesis because it is done with a needle, infection, pregnancy loss, and a fetal injury due to the needle. Results are definitive, however. They are not a guess. Once you are testing the amniotic fluid through this method, you are getting a definitive diagnosis and not just a guess of one. The fetal nuchal translucency test we do between about 10 to 14 weeks, and it's an intravaginal ultrasound which measures the fluid level in the fetus. So if it's greater than 2.5 millimeters, it is an abnormal finding. Abnormal fluid collection in the fetus is associated with certain genetic disorders, cardiac problems, and things like Turner syndrome or physical anomalies. It can detect 62% of all Down syndrome, and with blood testing, in addition to this, it can detect up to 73% of Down syndrome. So causes of death in pregnant women. So we're going to move on to that. 20% is homicide, which is the #1 cause of death in pregnant women versus 6% in non-pregnant women. So as you can see, homicide becomes a greater risk when you're pregnant than any other time during your life. 15% of death in women are due to postpartum hemorrhage. 15% is due to unsafe abortion complications. 10% is due to hypertensive disorders of pregnancy. 8% is due to postpartum infections. And 6% is due to labor and delivery complications. So when we talk about homicide, we're talking about violence and abuse. And why is that such on the rise when someone is pregnant. Well, there's a cycle of abuse and violence that will escalate specifically during this time. So violence does escalate in pregnancy due to a number of factors. It could be jealousy from the partner that the attention is no longer on him. It can be the stress financially and emotionally of the pregnancy, as well as the realization of having a baby. It could be that the baby is not wanted by the partner. It also could be a feeling of being now trapped or committed to someone that you didn't want to be now that a baby is involved. And that can escalate the abuse violence cycle. So there are 3 phases with this cycle. There's tension building, acute battery, and then the reconciliation phase, which we call the honeymoon phase. So in order to break the cycle, between phases 2 and 3, this is when they may be at the hospital getting treatment. So they have established something called the SAVE model. And the SAVE model is an acronym for screen, ask, validate, and evaluate. And this is a way that we can try to recognize those that are at risk of being in this violent, abusive relationship. So it's important that that this person has a plan of action to get out of this relationship. We have different informational pamphlets, if you will, where we talk about hiding your keys, money, credit cards, passwords, account information, and important documents in case you were to need to leave in an emergency. It's important to tell someone of your plan. We offer help as well as resources as far if someone is trying to get out of this abusive relationship. Obviously, it's important to do this SAVE model where we screen and ask and validate and evaluate when the person is alone, which is sometimes difficult to do in an abusive relationship because the partner doesn't often leave the patient alone because they're afraid the patient may tell someone else what's going on and they don't want that to be found out. So oftentimes we use the SAVE model in labor and delivery when we have to have the father leave the room because of a sterile procedure or a different, they may be getting ready for an epidural or something that we need to just have personnel in there, just staff. And so when the father has to leave the room or the partner has to leave the room, this might be a good time to ask if the patient is safe at home. Do they have a safe home to go home to? Have they had suffered abuse in the last few months? So this is important that this might be a time where the mother feels more comfortable to answer some of these questions openly and honestly when that partner is not around. So just something important for you to know. And it is part of the admission record for every labor and delivery patient who comes into the hospital. We are required as labor and delivery nurses to assess this, as well as when she goes to her prenatal visits, they ask a form of the SAVE model as well. So talking about pregnancy, we're talking about iron deficiency anemia. So 1 in 4 pregnancies is affected by this. It's because pregnancy demands iron stores, and many women just don't have enough of those stores to meet the need. So pregnant women need at least 27 milligrams a day. So hemoglobins of less than 11 at any time during the pregnancy are considered abnormal. And when a woman is anemic during her pregnancy, this can lead to preterm delivery, perinatal mortality, and postpartum depression. And it can also lead to babies being born with low birth weight and poor mental and psychomotor performance. So it's important that we recommend to our moms and we evaluate them for this anemia and for iron supplementation. The CDC, as well as the IOM and ACOG, all recommend that supplemental iron be about 30 milligrams a day. And then these are just the different ranges of anemia as far as if it's less than 11, with a hematocrit less than 35, with a low serum iron of less than 30. This is what would be considered anemia and where we'd want this supplemental iron. When a mom is anemic, she can feel fatigued, weak, anorexia, decreased immunity, and she can also get tachypnic too. So we have to be aware of looking for signs on our assessments that a mom could be anemic. But there's something called physiological anemia. And so we know that low hemoglobin and hematocrit can be normal during pregnancy. And this is called physiological anemia, and it's due to hemodilution. So physiological anemia of pregnancy is when plasma increase exceeds the red blood cell production. So normal hemoglobin and hematocrit will decrease. And this is called hemodilution, which why it appears that mom could be anemic, but it's more of a physiological anemia and less to do with her iron storage. The next thing we're going to talk about is pelvic support disorders. So it is recommended that Kegel and other preventative exercises are used to keep that pelvic floor strong. It's important that mom be at an ideal weight, that she give up smoking, she give up intra-abdominal pressures during the pregnancy like jogging, which can cause the pelvic floor to weaken. When a pelvic floor is weak, it can cause urinary and fecal incontinence, and it can also cause pelvic organ prolapse. So this could be a systole where the bladder prolapses, a rectocele, an enterocele, or a uterine prolapse where the uterus can fall right through that pelvic floor because it's not strong enough to support it. The next thing we're going to talk about is the uterus. So there are contractions called Braxton Hicks contractions, which are spontaneous, irregular, and painless uterine contractions. They can begin in the first trimester and continue or intensify during the last month of the pregnancy, but this is what helps thin and efface the cervix, which we already talked about is the opening of that uterus where the baby's coming out. As the uterus grows, 80 to 90% of the uterine blood flow will go to that placenta, which is feeding our baby. The diameter of the main artery that feeds the uterus will nearly double in its size. When we talk about the uterus, we can measure the top of the uterus. The top of the uterus is referred to as the fundus. So when we're measuring to the top of the uterus, we're measuring what we call fundal height. So the practitioner will take a tape measure and measure from the top of the pubic bone to the top of the uterus, and they'll do this in centimeters. This measurement will correlate to how many weeks gestation the woman is pregnant between the weeks of 18 to 32. So it doesn't correlate before 18 weeks. It doesn't really correlate after 32 weeks. But it is a good measurement to make sure that the baby is growing on track. If your measurement is 20 centimeters of fundal height at 19 or at 20 weeks of pregnancy, then your baby should be about 20 weeks in their growth. Obesity, hydramnios, which means not enough fluid or too much amniotic fluid, and uterine fibroids can interfere with the accuracy of this correlation. It can cause the uterus to be measuring too big or too small or irregularly because of those other factors. And it's part of that office visit assessment that pregnant women get fundal heights. Next thing we want to talk about is why does side lying help promote fetal well-being? Well, we know that the spine, the vena cava, and the aorta are all compressed when a woman who is pregnant and has a pregnant uterus lies on her back. And in that supine position, you can get hypotensive syndrome. So notice in this picture, this mom is lying on her back. The weight of the fetus in her uterus is pressing the vena cava against her spine. And so this can cause not only hypotensive syndrome in mom, but it can also cause a lack of blood flow and oxygen to get to baby. So think about this during labor when we talk about decelerations in the fetal heart rate, which we will in the upcoming weeks, and why it's important that we keep our moms on their side. Usually specifically the left side, which is the best blood flow to baby. However, anything off of her back is better. So we want to talk about the summary of changes that occurred to mom when we talk about anatomy and physiology during pregnancy. Her uterus will increase 20 times the size of a non-pregnant uterus. Her cervix will have changes. There'll be a mucus plug that forms that will keep the os or the opening closed or plugged to protect the fetus from bacterial invasion. The vagina will have changes where there'll be thickened mucus, and this will help prevent infections. The ovaries will have changes. They will enlarge. They will secrete hormones to maintain the pregnancy. And by about week 6 to 7, the placenta will take over. So initially in the pregnancy, What's maintaining it and keeping you pregnant is hormones that are secreted by these enlarged ovaries. After that time, about 6 to 7 weeks, the placenta is formed and implants, and that is what is taking over the rest of the pregnancy to maintain the pregnancy. The breast will change in size, in pigmentation, and blood vessels will increase. When we talk about dietary concerns for the pregnant woman, we talk about needing vitamins and dietary fiber. We want to make sure that she lowers her intake of saturated fats, trans fats, and cholesterol, that she increase or start taking a folic acid. She can get this from dark green vegetables, leafy vegetables, lettuce, peas, citrus fruits, and supplements. When we talk about fish, we want to make sure that she's avoiding mercury contamination. And so there's select fishes that she can eat, and we'll go over that in the antepartum slides. And that if she is going to choose some of those fishes, she should limit it to 2 meals per week because of the mercury content. She should avoid soft cheeses and processed meats due to the risk factor of getting a listeria infection from these foods. Her weight gain should depend on the BMI she was at the start of her pregnancy. If she were underweight, then we can recommend that she gain about 18.5 pounds. If she were, or she should gain more than that, if she was a healthy weight, she should gain between 18 and 25 pounds. And if she's overweight, she doesn't need to gain as much weight. If she's obese, 30 or higher, and you want to see the box in your textbook, which can show you how to calculate BMI if you need to do that. So that is our end of our anatomy and physiology slides. Thank you.